Good evening, everybody. Welcome to Understanding Your Prostate Disease and Available Treatment Options, Treating Benign Prostate Hyperplasia and Prostate Cancer with Tulsa Pro. So you remember, Tulsa Pro was one of our most popular presentations, and we're delighted to have Dr. Robert Staruch, PhD, Director of Clinical Science for Profound Medical, who's going to tell us all kinds of good things about the Tulsa procedure and Tulsa Pro. A little bit about organization if you're not familiar with Prostate Forum. We have monthly presentations led by top experts in their field. Get to know your potential treatment professional prior to visiting them. 2 online support groups on Zoom entirely each month. The newly diagnosed and active surveillance group meets on the 2nd Tuesday of every month, 12 months a year, and the advanced recurrent on the 4th Tuesday of every month. This is a relatively new treatment option for prostate cancer and BPH. Technology for magnetic resonance imaging guided transurethral ultrasound ablation of prostate cancer. Try saying that 3 times fast. Robert Staruch is Director of Clinical Science at Profound Medical. His team of scientists educate physicians and their teams on the Tulsa procedure and partners with them to continuously improve the technology and patient outcomes. Motivated by his own experience as a cancer survivor, his PhD focused on the technical development of MRI-guided ultrasound therapies. He has played a leading role in clinical studies evaluating Tulsa Pro and for tissue ablation in men with localized prostate cancer. Presentations are usually posted here, prostateforum.org/presentations. We'd love to hear from you, and we're looking for volunteers too. And here's our email again, prostateforumoc@gmail.com. Dr. Staruch, thank you for joining us. I'm going to mute myself and let you take it from here.
Great. Thank you so much, Neil. And yeah, thanks everyone for attending today. And thank the organizers for allowing me to present today. I think we intended to have a physician come to speak to you a little bit about Tulsa and some of the other treatment options, but there was a scheduling conflict, and I'm more than happy to pitch in. So as described, my name is Robert Staruch. I am with Profound Medical. I'm the Director of Clinical Science there. I've been involved with the development of this technology, as well as the early phase and more recent clinical trials, and just happy to present a little bit about some of the prostate disease options that are out there, and a little bit more detail about Tulsa, and look forward to all of your questions. So here's disclosure. So today's agenda, it's a little bit broad, but I'll talk a little bit about the prostate anatomy, mostly about prostate cancer, and an introduction to the Tulsa procedure and some of the clinical evidence that's been published related to the Tulsa procedure. So I think this is probably a little bit pedantic for this audience. You guys know a lot about this, but the prostate gland, it is positioned here between the rectum and the pubic symphysis underneath the bladder. And importantly, the urethra passes right through the center of the prostate to let the urine flow out of it. And that's where the transurethral ultrasound applicator is going to be inserted in our procedure. The 2 disease processes that we mostly concern ourselves with in terms of the ablative therapies would be prostate cancer, as well as the lower urinary tract symptoms that are caused by BPH. And, those range from urgency and nocturia and dysuria and all of these other symptoms. So a little bit on the statistics and definition of prostate cancer. So certainly the prognosis of prostate cancer depends on the stage of the disease. So is it still within the prostate and localized in somewhere that a local therapy can be treated, and also how aggressively it might grow. So that's the pathological grade. There's typically no symptoms, and so you require screening in order to detect prostate cancer. It's obviously very prevalent, and it is the second leading cause of cancer death in the U.S. And many men will be diagnosed with prostate cancer in their lifetimes. So that screening typically is driven by the PSA test and the digital rectal exam. And though the PSA increases with a variety of things, including the size of the gland, age, conditions like BPH or other conditions like prostatitis. And if the PSA level is abnormal, then a primary care physician might refer a patient to go see a urologist to do some additional testing for their prostate cancer. And perhaps this used to be flipped the other way around, that a biopsy would be the first place to go after an elevated PSA. And I think that things are changing a little bit now, where the detection, the diagnosis, and as I'll present a little bit later, even the treatment and follow-up for prostate cancer are increasingly becoming MRI centric. And so prostate MRI allows us to visualize cancers very well, and with using standardized methods for reading and acquiring those MR images with multiparametric or biparametric approaches, it can even be used to decide whether a patient should have a biopsy now or can defer it for a little bit later, and obviously also to target where those biopsy samples are acquired. And then once that biopsy is performed, whether it's a targeted or a systematic biopsy, whether it goes through the rectum or it's transperineal, those samples would then be sent to pathology and graded, and that grade definitely has an impact on the overall risk level of that individual's cancer. So if the disease is localized to the prostate and the patient is appropriate for a localized management approach, for example, with a favorable intermediate risk, then really all of these treatments here are on the table for those types of patients. I think at this point, the different active treatment methods like radiation and prostatectomy, they're very different, and they have slightly different side effects. They're all effective, and I think it's becoming more of a choice for the patient about what types of side effects are the ones that they feel they'll be able to adapt to after the treatment. And so on the bottom here, talking a little bit about ablation. And so this is trying to destroy the tissue without resorting to removing the entire gland through surgery or using radiation in order to control the disease with less morbidity. And there are a variety of approaches to that. And of course, I'll talk a little bit about Tulsa. With regards to these other approaches with active surveillance, it's for men that have lower risk cancers, favorable intermediate risk. Some of those patients can be closely monitored with annual DRE exams and regular PSA testing, as well as periodic biopsies and MR imaging tests. The benefits of this are that you can avoid the side effects of these treatments, but some of the risks are that the patient and their family needs to live with the anxiety of still having the disease in the prostate. Perhaps they're concerned that they might be passing the window at which they would have the ability to get definitive treatment without having any compromise in their cure or quality of life. There's discomfort associated with getting repeated biopsies. And then eventually a lot of these patients end up getting definitive treatment. But certainly postponing that treatment is valuable, and there are certainly a large number of men that would be able to avoid treatment altogether. And then the other approaches, so radical prostatectomy, obviously, if the disease is within the prostate, then this provides an excellent chance of cure. There's a lot of data supporting radical prostatectomy over time, but it's a major surgery, and so after the couple of days of hospital stay, there is a relatively long recovery time for urinary continence and erectile function to recover. I know some of the physicians that I speak to, even very experienced robotic radical prostatectomists, they typically counsel their patients that there's maybe a 50-50 shot that they'll regain their erectile function after surgery, and that most of these patients will have to take some time to recover their urinary continence after the procedure. Radiation therapy. So there, you're using the high energy rays in order to damage the DNA of the cancer cells, and with the expectation that they have limited ability to recover compared to the surrounding normal cells. And so this, it's not exactly killing all the cancer cells directly, or at least immediately. It's more that it's just preventing the proliferation of those cells. And one of the things that's related to that is that it takes a little while before those benefits can be confirmed. It's maybe a couple of years before the PSA will reach its nadir, before in some cases maybe a biopsy would be performed, although that's pretty rare. Some of the advantages are that there's been a lot of technological development in this area. So there's all of these different options that can reduce the number of fractions, that can improve the precision, and that can also avoid some of the toxicities by placing space between the treatment plan and the rectal wall. So there are definitely a lot of advances here. There's still a few types of side effects that continue to be an issue in terms of the kind of middle term erectile dysfunction that increases a little bit in the first few years, as well as some of the urinary complications that and bother that occurs over time. So in order to avoid some of those treatments, but also avoid some of the side effects associated with those treatments, but also achieve a high rate of cure, and hopefully avoid some of the anxiety associated with active surveillance, we have these focal therapy approaches targeting part of the prostate up to the entire gland. And this is using other techniques other than radiation or surgery, many of them using thermal methods in order to either freeze or heat the tissue to the point that it's irreversibly damaged. A couple of those techniques, just briefly. So high intensity focused ultrasound that I'm sure many of you are familiar with, where ultrasound waves are passed from a device that's placed within the rectum across the rectal wall to a single point to rapidly heat and destroy the targeted prostate tissue. And then a larger volume is treated by moving that single point to different locations. Some of the benefits here that you can repeat a treatment like this, because it's situated within the prostate, it's very amenable to treating targets in the back half of the prostate gland. And it's very amenable to doing small targeted volumes, especially in the posterior part of the prostate. It's not necessarily a risk, but that this approach of doing very focal treatments with only a small region of the prostate is not necessarily applicable to all patients. Many will have multifocal disease, or their disease extends beyond a small part of the prostate. And at least in the early studies of HIFU, when it was being applied in more of a whole gland approach, there were relatively high rates of erectile dysfunction, incontinence, urinary symptoms that really led the way to most of these treatments being done in more of a focal manner. Some of the same can be said for cryotherapy, where you're using these repeated freeze-thaw cycles to destroy tissue, using needles that are typically advanced transperineally. again, it's a single-day treatment. It's less invasive than surgery. Shorter recovery times can be repeated. But this one, perhaps, some of the physicians that we talked to say that it's quite operator dependent, and some physicians are, highly experienced and are very good with using the ultrasound imaging to guide their needle placement, to ensure that they're able to get very good overlap between their different freezing zones, and to ensure that they have great outcomes. But there can obviously be issues with where the treatment extends to, because the ice ball that's being visualized, whether they're using ultrasound guidance or MR guidance, is typically a little bit further than where the actual treatment effect is occurring. And so they can't necessarily see the edge of the region that's achieving a permanent effect. And again, as mentioned, some of the earlier studies using probably more of a whole gland fashion had higher rates of erectile dysfunction, which led the field to going more towards the focal approach. So with that, I'll start talking a little bit more about the Tulsa procedure and how it's been designed in order to address some of the shortcomings of other attempts to deliver less invasive prostate treatments in the past. I'll talk a little bit about how it works, some of the clinical studies that have been published in this area, and show maybe an example of the workflow, and close with some things about how available this is in different parts of the country. So Tulsa stands for transurethral ultrasound ablation. It's transurethral because the urologist is able to slide the active part of the ultrasound applicator through the urethra to put the active part of the transducer within the prostatic urethra, and the tip extends into the bladder. Ultrasound, because it's using ultrasound similar to HIFU, but different in terms of using 10 parallel beams of sound, as opposed to focusing energy into one small point. And so here we have these 10 independent transducers that are each emitting a beam that's 5 millimeters by 5 millimeters and has a maximum depth of 3 centimeters. So it, in effect, forms this blade of ultrasound that really allows the physician to treat larger areas more quickly. So this blade of ultrasound is then swept robotically through the prostate while doing real-time imaging to visualize the effect. During the ablative procedure with the Tulsa device, there is cold fluid being pumped through the inner channel of the ultrasound applicator, as well as a device that goes into the rectum just to cool the anterior rectal wall and provide an additional level of protection there. So because the device is coming in from the middle of the prostate and heating outwards, and because of this kind of fan blade or 10 parallel beams of ultrasound, as opposed to focusing to a single point, it can really expose a lot more tissue at the same time, allowing for wider treatment volumes that can range from a small focal sector up to the entire prostate, really whatever the physician chooses to prescribe. And it can do so both efficiently and also very precisely because of the use of this ultrasound energy, and as I'll describe on the next slide, the temperature monitoring and control. So the procedure is performed in an MRI scanner, and the reason why it's done this way is so that we can monitor the temperature during the ablation in real time. We're also able to acquire real-time images of the anatomy of the prostate when the physician is planning the treatment. So in this situation, you don't have to have an image overlay, an image fusion between kind of a historical image that was acquired during diagnosis and the images that are being acquired during the therapy, you're really able to acquire images that the physician is used to reading to identify locations that they'd like to treat in real time at the magnet after the devices are placed, which does kind of distort the overall shape of the prostate. And at that point, they can still see the parts of the anatomy that they'd like to target. So I'll let this loop around, but when the device is placed in the prostate, they will do a couple steps in the planning and eventually acquire images that are perpendicular to each of the 10 transducer elements. And these are T2 weighted images. They can also import diffusion weighted images and use those images to contour very specifically exactly the ablation volume that they want to treat. So you can see the black line here on each of these slices that are going from the apex to the base of the prostate. Those are the intended ablation volumes that are defined by the physician. And they can choose to ablate a small sector of the gland, or in this case, it's really the entire prostate. And then you can see these color overlays, which are displayed.
Join the meeting
During the ablative procedure. And those color overlays are related to the temperature in the prostate, which is measured quantitatively. Every 5 seconds during the treatment, there's a volume of images that spans from beyond the apex to beyond the base of the gland, and a fairly wide field of view into the rest of the pelvis, which then with a resolution of 2 millimeters by 2 millimeters shows the actual temperature in every spot of the prostate and the surrounding tissues, which the physician can then use to make changes to their ablation plan, or to decide to pause and abort the treatment if necessary. While that's happening, the software of the Tulsa Pro system is using that temperature information to, in real time, make decisions about the ultrasound power that should be used for each of the transducer elements, the frequency that each of those ultrasound elements should use, which controls the ablation depth, and how fast to rotate the device. And that time of exposure related to the rotation of the device, and then the amount of ultrasound energy that's emitted is then causing different rates of temperature rise, which allows the physician to control exactly what temperatures they want within the prostate. The software is tuned to achieve a coagulative temperature, a thermal coagulative temperature of 55 degrees Celsius at the target boundary that the physician has prescribed, and the heating extends from that point inwards all the way to the device. So you have temperatures kind of between 55 and 86 degrees throughout the prostate between the device and the target boundary. At the end of the procedure, the device is removed, and the patient will typically go home with a catheter, and I'll talk a little bit more about that at the end. So the timeline of the development of this technology, so it was really started about 20 years ago with simulation studies, and then experimental work and dog studies in order to demonstrate the ability to match the ablation volume with the intended treatment that a physician wants to give. There were first-in-man studies done in the early 2010s that established the ability to actually put this device in a patient, ablate their tissue, see the temperature rise in the patient's prostate. And then in those first studies, those were done by Dr. Klotz at Sunnybrook. He actually performed the radical prostatectomy immediately after the Tulsa procedure, and the histology from the prostatectomy samples was then compared one-to-one with the temperature images from the Tulsa system, which was very informative for the further development of the technology to know what temperatures correlate with cell death and what exposures our controller should work towards. And so that's really how our system has been designed. The company performed a phase 1 clinical trial that demonstrated the safety of the technology, which gave the technology approval in Europe. And then I'll talk a little bit about the pivotal trial that was performed in the US, Europe, and Canada, which garnered FDA clearance for the technology. So this is the overview of that clinical trial, which is our pivotal study for our FDA clearance. We call that the TACT trial, and it stands for Tulsa Pro Ablation Clinical Trial. The population of patients in this study was 115 patients across 13 sites in 5 countries, a lot of academic centers in the US and Europe and Canada. Most of the men had intermediate risk, biopsy-proven localized prostate cancer. Many of them had disease on both sides of the prostate or had greater than 5 out of 12 cores positive on their biopsy. So these are patients that had, most of these patients had disease that was not really a unifocal kind of situation where a more focal approach would be appropriate. You know, a lot of patients have disease in more than one location in the gland, and that was quite amenable to this treatment. The bar for FDA clearance was to demonstrate prostate tissue ablation, and so the endpoints and the treatment design for this study were to do whole gland treatment, sparing a little bit of tissue at the urethra, at the apex, and at the base, but nominally whole gland treatment. And the main endpoints were to look at the PSA reduction, the prostate volume reduction, adverse events. And then we also looked at some of the more clinically relevant endpoints related to biopsy, MR, and quality of life. We now have 4-year follow-up that I'll describe, but we are collecting the 5-year data from the patients now, and we are looking forward to having more insights into that from the physicians that were participating in the study. And you can see here that some places where you can find more information about it. The main endpoints and the main outcomes of the study, so the primary for FDA purposes was the PSA reduction, and we demonstrated a median 96% decline in PSA levels from baseline to the lowest level. And those remained low to 4 years after treatment. The prostate volume as measured by pre and post Tulsa MR, the post being at 1 year after the treatment, decreased 91% from a median prostate volume of 37 cubic centimeters, pretty typical, down to 3 cc's, which is really a small volume. And then at 1 year, a 10-core biopsy was performed, and so that's 10 cores into that dramatically reduced prostate volume. This is certainly a higher biopsy density than most of the urologists were used to, and kind of approaches and actually maybe exceeds in most cases the saturation biopsies that are sometimes performed. And after this extensive biopsy sampling, we found that 80% of the patients had no grade group 2 clinically significant disease in their prostate, and 14% of patients only had low volume grade group 1 disease. So at 4 years now, 16% of the patients in the study have gone on to have additional cancer treatment. Since the study was performed before the clearance, Tulsa wasn't available for salvage treatment for those patients. About half of them ended up going for radical prostatectomy, and the other half radiotherapy. And so with the 5-year follow-up, we're hoping to see some more outcomes from how those patients did after their salvage treatments. But there are additional publications out there already from some early experience with radical prostatectomy after Tulsa Pro. Safety, so the rate of serious or severe adverse events was 8%, and these primarily urinary tract infections that required IV antibiotics. And then there were 2 or 3 patients that had urethral stricture or urinary retention that needed endoscopic intervention. So they needed to go in afterwards to cut out a little bit of tissue in order to open up the bladder neck. And so the physicians that were involved with those patients, they described it as either resection of a small amount of residual necrotic tissue, or just opening up a point closure of the urethra. Not really the same degree of difficulty or sequelae as some of the strictures that extend for a few centimeters within the urethra. And since we have the cooling and we're coming from the urethral direction outwards, there have been no rectal injuries. In terms of continence, which is shown in the plot on the left, and erectile function on the right, so 99% of patients had either 1 or 0 pads, and so effectively there's one patient that was using more than one pad after Tulsa, and then to 4 years, 6% of the patients in this study are still using a pad, kind of security pad, or one that they wear at night, and so it's 94%, the inverse of that, are pad free. On the erectile function side, so here we're looking at erections firm enough for penetration using the IIEF questionnaire, and there is a decrease in the first weeks after the treatment, but that recovers very quickly. And by 4 years, we have 87% of the patients have reported that their erectile function has recovered after Tulsa. So that's from our FDA study that earned clearance for the device in 2019. So since then, in the intervening years, a number of physicians have adopted the technology in the United States. We also got Health Canada approval that year. But the device has been CE marked for use in Europe since 2016. And so there's additional clinical evidence that's now been published by some of the physicians who adopted the technology earlier on. This paper that I'm summarizing here is from Dr. Agron Lumiani from the Alta Clinic in Germany. He was one of the first to use this outside of clinical trials, and he published on his first 52 patients. And so some of the characteristics of the way that he was delivering the treatment as opposed to clinical trials are that, a broader selection of patients were included. So, mostly intermediate risk, but instead of having some low risk, he had some high risk patients. So those with higher grade groups, grade group 4. And then also the treatment plans were different. And so instead of nearly whole gland ablation, as in the TACT clinical trial that I just described, in his real world experience, he was mostly doing partial gland ablation. And some of those patients, the majority of those patients, there was nerve sparing on at least one of the sides. And interestingly, about half of his patients fit a different kind of characteristic that we hadn't originally anticipated, but it was the combination treatment of focal cancer and debulking of BPH. And so his approach was for patients that had a lesion in one part of the prostate, but also were experiencing lower urinary tract symptoms that they were maybe taking medication for that was associated with hyperplasia of the prostate. He would choose to ablate a larger volume of prostate tissue in those patients that included the area that he felt was suspicious for cancer and was biopsy confirmed, but also sweeping through the anterior transition zone through that enlarged part of the prostate that was causing the urinary blockages. And so in his patients, he found that the safety profile was very similar to what was observed in the clinical trial. Only one patient who was wearing a pad at night. A couple patients required, again, endoscopic resection of residual tissue, but all in his early practice reported that they maintained erectile potency. Some of the efficacy outcomes. So after the first Tulsa treatment, 73% had a negative MRI and no PSA failure. So of those ones that had a positive MRI, 9 of them underwent a repeat TULSA to address the part of the prostate that wasn't completely ablated on the first treatment, or where additional disease occurred in the months after the original treatment. And then after that second TULSA procedure, that rate of negative MRI and PSA increased to 88%. And so this is in the 1 to 2 year time range after TULSA. And of the patients that sought relief from their urinary tract symptoms in addition to cancer, 83% of those patients with the lower urinary tract symptoms had symptom improvement. Another group of patients that there's been data published from another European group is in patients that have localized radio-recurrence after undergoing initially radiotherapy for their localized prostate cancer. And so this data is published by the team at the University of Turku in Turku, Finland, led by Dr. Mikhail Antonin. So they designed their own trial that was run independently, where they, they did a few different arms, but in this particular arm of the trial, they were treating men that had localized radio-recurrent prostate cancer. They published a preliminary report with the first 11 patients and are now approaching their 40th and have been publishing at some of the conferences along the way. And so in their initial report, which is the data that I'm showing here from their paper, based on their 1 year MRI, PSMA, and biopsy after that first treatment, only 1 of their patients had a positive biopsy on the same side that they intended to treat. And 2 patients had positive biopsy out of field, and these were actually in the seminal vesicles, so not really within the region that could have been targeted with TULSA. They've pointed out that all of the recurrences were visible on PSMA PET imaging. They had the luxury of being able to use that for all of their patients, and found that to be a very useful tool for identifying residual disease in this particular setting. The safety profile is quite promising. There was 1 urinary retention that required dilation, and then some that just required a temporary recatheterization shortly after the treatment. So one thing that I'm personally quite excited about is the fact that we already have our clearance, and we have physicians that are adopting the technology in the United States, Canada, and Europe. But we're still looking to build additional evidence supporting or identifying the role of TULSA among standard of care treatments and against standard of care treatments. And so we're sponsoring a randomized trial of TULSA against radical prostatectomy in men that have intermediate risk prostate cancer. That's grade group 2 and 3. And we call this the CAPTAIN trial. And we are looking to see if at 1 year after TULSA that patients who undergo TULSA have maintained pad-free urinary continence and erections sufficient for penetration at a higher rate than those that undergo surgery. And then our primary efficacy endpoint will be evaluated at 3 years to see how many patients have undergone additional interventions for prostate cancer or gone on to have progression of their disease. And so it's important to note that the intervention on the TULSA arm, so this is kind of more than hemigland ablation, less than whole gland ablation, kind of customized approach in terms of the ablation plan. They're allowed to have a second TULSA if at 1 year they find that there is residual disease and they choose to target it before that assessment of the efficacy at 3 years. So this was designed mainly by our clinical advisory board, and they felt that this was a very fair comparison. And it does match up fairly well with some of the other efforts in this space in terms of comparing ablative treatments to standard of care that have come from the UK or other places in Europe. So while the primary endpoints will be assessed at 1 and 3 years, we'll also follow those patients for up to 10 years for collecting information about survival, which will allow a more meaningful comparison of Tulsa to standard of care treatments. We won't necessarily be able to prove anything at the 10-year follow-up time point because the study is powered to look at that 3-year efficacy as opposed to longer-term follow-up. With these patients, we don't really expect that many in either treatment to have prostate cancer specific death or a significant rates of biochemical failure. We'll also look at the rates of complication as well, both in the short term and in the longer term for both of these treatments. The quality of life for these patients, both from the urinary, sexual, and overall domains. We'll also look to collect some data on the cost effectiveness of these 2 treatments. And so the study is now enrolling at, I think there's probably 8 or 9 sites. You can definitely find additional information at clinicaltrials.gov for this study. But we're quite excited about it because there still remains no randomized trial evidence comparing ablative therapies with radical prostatectomy in this patient population. And you can see the clinical guidelines, especially the one from Europe, asking for studies of this nature to be performed. And we're very excited to be on the front lines of doing that and eager to see if we're able to meet the challenges of recruiting to a study of this nature, because it's very challenging to get patients and physicians on board to randomize between 2 different treatments, but also to see the outcomes to determine what the role might be for Tulsa Pro compared to standard of care. I'll talk a little bit about what the patient experience would be kind of before, during, and after Tulsa. So before Tulsa, of course, there's the disease detection, diagnosis, and staging. We talked a little bit about that. There would be a urologist visit where all of the available treatment options are presented to the patient, and they have that discussion that I know that you guys here at the Prostate Forum talk about very frequently. If the patient is deciding to go towards Tulsa treatment, one of the things that they would do is have either a CT or a specialized MRI to assess whether whether that patient could be eligible for Tulsa. The CT would tell if there's any calcifications within the prostate that are large enough and in a concerning location that might impact the ability to deliver an adequate treatment. And MR would be used to kind of gauge the dimensions of the prostate to determine if the prostate is sized appropriately for Tulsa treatment, and also that there are no other abnormalities of the prostate that might preclude the treatment from undergoing Tulsa. The patient would get medically cleared by their primary care physician because the Tulsa procedure is done under general anesthesia. They would typically meet with a nurse in the urologist's office to talk about their pre and post-op care. There is a bowel prep before the treatment day, which includes a special diet, as well as an enema on the day before or the day of the treatment. And certainly the Tulsa physician would have details on that. The treatment will happen, and I'll talk a little bit more about that afterwards. And so on the treatment day, there would be an enema. The nurse would meet with the patient. The anesthesiologist would start to administer some of the medications, an antibiotic, anti-inflammatory. And then after the patient is sedated, they move on to having the devices inserted, being positioned in the MRI, and undergoing imaging, treatment, and then finally recovering from their treatment after the procedure. And the follow-up visits would be fairly typical for other prostate cancer interventions with PSA, quality of life checks, eventually MRI, and if warranted, biopsy at the kind of 6 to 12 month range. So again, on treatment day, The preparation of the patient would typically be done in a prep area just outside the MRI room. There'd be a timeout done in order to ensure that everyone's on the same page in terms of their roles for the procedure. The patient would be sedated and brought into the MRI room where the device is inserted and the patient is positioned for imaging. The images are acquired with the device in place, with the patient in the magnet, and immediately imported into the Tulsa Pro software so that the physician can design the treatment plan according to the conversations that they had with the patient beforehand about their goals for the treatment, whether it's biased more towards avoiding the possibility of requiring retreatment, or whether it's more on the side of preserving as much tissue as possible. And that's certainly a conversation between the physician and patient. Once the plan is designed, then the treatment is performed automatically under this real-time temperature imaging control, where the MRI is acquiring images that are then transferred to our software. The temperature is calculated and displayed. That temperature is also used to adjust the treatment parameters so that the treatment matches the physician's intended ablation volume. And then the physician is there to intervene and adjust the plan as needed as it proceeds. And then after they decide to end the treatment because they've ablated the intended volume of prostate tissue, then typically a scan is performed after injection of a gadolinium-based contrast agent in order to assess the volume of prostate tissue that has been devascularized. The blood vessels in that region have undergone thermal coagulation and are no longer bringing the contrast agent to those regions. And so it really shows this immediate impact of the tissue that's been ablated successfully. So what that looks like in the software, some of the steps that the physician would perform. The first step would be to import the images into the software, and they'll contour the intended prostate volume that they'd like to ablate. And so they do that in our software just by tracing out the volume of tissue that they want to include. And all the tissue up to that line will be the goal of the software will be to achieve a temperature of 55 degrees Celsius in all of the tissue within that target contour. On the left-hand side, you see the color image. And so that's showing a preliminary test set of temperature maps that indicates the quality of the temperature imaging in those regions of the prostate. So within the prostate, it's this light blue color, which indicates that the variation in temperature measurement is very low. And then outside of the prostate, in some of the regions that are covered with fat or where there's bone, those regions have this purple color, which indicates that the temperature measurement is less certain in those areas. And this temperature measurement technique works in the soft tissues of the prostate and surrounding tissue. So they define their treatment, they verify it on all the different slices from the apex to the base of the gland. They can also see it in other views to confirm that this gold boundary that they've defined covers all of the prostate tissue that they'd like to ablate. And then they move on to the next step, which is actually delivering the treatment. And so this is the view that the physician will have when they're delivering the treatment. There's these two strips at the top that show different views of the temperature overlay information. One can be the current temperature, and one is the cumulative maximum temperature that's occurred during the treatment. And then when they select one of those, now these are all representing individual transducer elements. And so different parts of the prostate that are treated by different parts of the ultrasound transducer. And so if they select one of those for closer examination, it'll appear here in the main viewport. And so this video is dramatically sped up. Typically, the device is rotating at a rate of about 2 to 10 degrees per minute, so that to ablate a 40 or 50 cc prostate takes about 40 to 50 minutes. And so this kind of whole process of ablating and rotating the device to sweep the heating region through the entire prostate gland for a prostate of the size shown here is about 50 minutes. While that ablation is ongoing, you can now see like those color overlays demonstrating where the tissue is currently elevated, and temperature colors that are yellow and higher are expected to be coagulative, and those that are in the green range require a little bit more time in order to achieve thermal coagulation. They can also flip back and forth between the slices that look at different parts of the prostate, and during the treatment they can also, as mentioned before, pause and adjust the target boundaries if there's been a little bit of swelling of some of the prostate tissue, which can happen, or a small amount of motion. So after that, as mentioned before, the devices will be removed. The patient will be recovered from anesthesia. They'll go home the same day. And importantly, they'll, I guess we have that a little bit here. So there are some medications that the patient is likely to take afterwards. And certainly your physician would be the one to prescribe any medications here. But some of the basic ones that are very common would be an antibiotic, a short course of antibiotics immediately afterwards in order to address and prevent any infections, urinary tract infections. Often there'll be an anti-inflammatory because there will be a lot of swelling of the prostate tissue after the ablation, which can compress the urethra and cause issues with voiding in the short term, in the first week or two after the procedure. And so there'll be the anti-inflammatories, and then there'll be a catheter that will be placed on the day of the treatment, and that the patient will go home with that catheter. And depending on the ablation volume, they may have that catheter. I think in our TAC clinical trial, it was about 2 weeks. If the ablation volume is less than whole gland, I know a lot of the physicians are kind of closer to 1 week of having the catheter in place. In some centers, especially in European ones, physicians prefer using a suprapubic catheter. And that was also used in some of our clinical trials. But more commonly in the US, patients are opting for a Foley catheter that goes directly into the urethra. And it's largely a matter of patient and physician preference. So typically, there's not a lot of pain after the procedure. We did not see high rates of adverse events related to pain in the TAC trial or after the trial. So patients do get back to their daily activities very quickly. That's one of the advantages of most focal therapy procedures. And I think maybe you can see from the kinds of treatments that we're delivering here, this is, focal therapy, but it can also be extended to closer to whole gland therapy as well. So candidates for the Tulsa procedure, clearly they need to be eligible for MRI. So that can exclude men with certain types of metallic or genitourinary implants. Certainly, there are some, I think like a deep brain stimulator, I don't think we would be able to work with. And there are some pacemakers that are not MRI compatible that could be an issue. We definitely want to know about those beforehand. If there are particular precautions that can safely be taken to ensure that those patients can be treated. They need to be eligible for general anesthesia. As mentioned, that would be assessed by typically the primary care physician. And then I briefly touched on the idea of there being calcifications in the prostate. So these are small stones essentially, and if those are large with respect to the size of the ultrasound beam, and if they're directly in front of the ultrasound beam, positioned in an inopportune location within the prostate between the ultrasound applicator and the part of the prostate that the physician would like to treat, then that could be a reason for the patient being not selected for the Tulsa procedure. Certainly all of these things would be decided by you and the treatment physician. So there's a few testimonials, and you can find more of this kind of thing on the Tulsa Pro website. So tulsaprocedure.com, and definitely encourage you to take a look there if you're interested in learning more. on that website, you can also see which sites are looking for patients and are offering the Tulsa procedure that might be closer to you. So definitely encourage you to check the website if you're interested. And with that, I'll close for tonight, and happy to take your questions. There are a couple of links here, again, the tulsaprocedure.com website, as well as the clinicaltrials.gov website for our CAPTAIN randomized trial of Tulsa against radical prostatectomy. So thanks very much. I'll close my screen now so I can see you guys and take your questions.
Robert, thank you so much for a wonderful presentation. I know we've learned a lot from it. Dr. Metzger, do you have something to add here?
Yes, I just wanted to say thank you. That's about as complete a explanation about a procedure as we've ever had on this foundation. Thank you so much. It was so well illustrated, and even I understood it. So that's really remarkable. And thank you for your presentation style. It's just great to have this quality as a speaker. This will be a well-viewed video, and we sure appreciate it. We've had lots of questions about Tulsa procedure, how it fits in, where it fits in. This was particularly requested by Francis, one of our newer members. So this is for him and anyone else. I do think that we're not using it enough for focal therapy. Focal therapy, we had Dr. Marks from UCLA on not too long ago. And focal therapy is something that it just doesn't seem to be done as much as perhaps could be, and especially in some of our high anxiety active surveillance people, it probably would fit in very nicely in a lot of cases. So anyways, we certainly appreciate it. We'll leave it open to questions from our guys.
Thank you so much, Dr. Metzger. It's a pleasure to be able to speak with the group here. Definitely when it comes to focal therapy, most of the company-sponsored trials to date have been closer to whole gland ablation, but we do know that some of the academic institutions that have been doing TULSA since, they have been tracking their data and have a lot of information about outcomes of TULSA for more of the lesion target ablations. And I think that we'll be seeing some of that data soon, so stay tuned for that. Yeah, definitely looking forward to hearing some of the questions tonight. So
thank you.
Super. Dominic has a question. Is the patient moved along the axis of the tool to collect the 10 parallel cross-section images, or are the 10 images obtained simultaneously?
Right. So the MRI, one of the big advantages of MRI is that you can acquire images along a larger volume without having to move the patient. And so in the way that we acquire both the images used to define the target volume as well as to monitor the temperature in that target volume, that target volume is generally centered within the magnet, and all of those slices are acquired during the treatment, and so without moving the patient. So the planning images, they take a couple minutes to acquire, and that's done before the treatment is initiated. The treatment images, we get the full collection of 12 slices, which include the 10 slices used for therapy, plus an extra slice on either side to monitor kind of any heating that's conducting outwards into surrounding tissue, just in case. We get those images every 5 to 6 seconds during the ablation continuously in a loop. So the patient's not moved for any of that. And while those images are being acquired every 5 to 6 seconds, each of those transducer elements, they're firing at the same time. And they're all making their own logical decisions in order to adjust the power that they emit, as well as the frequency that they use in order to ablate the intended tissue volume.
Excellent. Is this covered by Medicare?
So, I mean, that's not my strongest area of expertise, but what I do understand is that there is a Medicare code that is available for the procedure. It's for MRI guided ultrasound ablations. many of our sites that are eligible to bill for Medicare are getting reimbursed for it. But you know, beyond that, I think that we'd have to defer to some of those sites on what's happening.
Is there a prostate size above which the Tulsa Pro cannot be used for BPH?
BPH. So that's a great question. So instead of volume, we're typically looking at the linear dimensions when we want to determine whether a prostate is going to be adequately targeted with TULSA or not. So if you have the device kind of as a this brass rod within the urethra, the beam comes out perpendicular, and the depth to which we can heat is 3 centimeters. And so anything that's within a 3 centimeter radius around the device can be very adequately targeted. And also, if it's the length of the ablation zone of the 10 elements is 5 centimeters. So in one sonication, 5 centimeters can be targeted. We have seen some physicians for patients that have a disease or a prostate extent that's a little bit longer than that, they would ablate one location and then they would move the device and ablate another location. So the largest prostate volume that I'm aware of, there was a patient treated not too long ago that had a 214 cc gland, and I think about 130 cc's of that prostate were targeted. So that's the anterior transition zone without really treating the posterior part of the prostate. The physician just chose to treat a section of the prostate that would be hopefully working for the lower urinary tract symptoms.
Can you have TULSA if you've had TURP?
Right. So in our clinical trial for our FDA clearance, we had pretty rigorous criteria. You know, it was still pretty early days in terms of our overall experience with the technology. And so in the TAC trial, that was not allowed. But in the post trial setting, I think that we have had some physicians treat patients that have had a history of having a TURP. That's happened a number of times, both in the European experience and the US experience. It doesn't really change things that much.
What would you say the ballpark cost is for Tulsa Pro?
Yeah, so again, not my real area of expertise. I think that when Dr. Princenthal was on the program and talked a little bit about Tulsa in his presentation, I think he was saying that it was in the ballpark of $30,000, which I think is still true today. So, you know, that would be, I think, what patients would be paying in a cash-based scenario. And then there are those that are doing this through Medicare, and I think that some are also successfully getting private insurance coverage, but probably at a lower rate than the Medicare.
Okay. How about cancer and post-prostatectomy reoccurrence? Could we use this, let's say, to treat the prostate bed?
So I did see Dr. Klotz presented on this at one of the conferences last year. He did treat one patient that had that kind of scenario, or it was a number of years after prostatectomy, and there was some tissue there to target. One of the things to help determine whether a patient would be amenable to having prostate tissue ablated in that setting would be if there's still enough prostate tissue to target. So in general, we're looking for a minimum treatment depth of about 10 millimeters. So if there's too little prostate tissue, then this wouldn't be a great option for those patients either.
Okay. You know, when I think of ultrasound for ablation, I think of HIFU.
Mm-hmm.
And obviously there's an MRI aspect to this. What should we know about a comparison of HIFU to Tulsa Pro?
Right. So, I mean, in some ways they're complementary, right? So the HIFU approach, you're coming from the rectum up across the rectal wall into the prostate, focusing to a single point at a time, and then raster scanning that in order to cover a volume. And so that's well suited to targets in the bottom half of the prostate, and especially for smaller volumes that a physician would like to treat. With Tulsa, you're up in the middle of the prostate. You have access to the anterior part as well as the posterior part of the prostate. But for example, I mentioned that there's some prostates that might have a radius to the outer edge that's larger than 3 centimeters. And so getting to that target from the inside out might not be as easy as getting that same target from the bottom up. And so we do have some treatment centers where they have Tulsa. They also have other devices, and they through similar processes to what happens at a lot of other academic centers, they'll have a multidisciplinary tumor board. They'll talk about the case, and they'll work with the patient also to decide what might be the optimal approach for each individual patient. And I think that makes a lot of sense.
So this is not something that will replace HIFU necessarily.
I think that the range of patients that can be treated with Tulsa, because of the larger ablation volumes that it's capable of, means that there's maybe a larger selection of patients that can be treated with this technology versus the HIFU technology. But I think there's still going to be a place for that as well as other approaches.
Robert, I want to thank you very much for your time. And we're looking forward to having you back. With that, the Prostate Forum is looking for volunteers for a wide range of positions and talents. Please give us a call at 714-549-2058 or prostateforumoc@gmail.com. And we'd love to talk to you about volunteering. With that, unless anybody else has questions, I'd like to say good night and thank you again for such a wonderful presentation.